work as medical oncologist in New Delhi, India, and I will be speaking on this case on renal cell carcinoma relapsing in brain 12 years after surgery. So, Mr. RP, 76-year-old gentleman, hypertensive for last 27 years, also having coronary artery disease for which he underwent CABG 23 years back. 2005 he was diagnosed with a left renal mass and he underwent nephrectomy elsewhere. The histopathology report was suggestive of clear cell renal RCC. Pathological T2N0, Foreman's grade was not mentioned there. So he was asymptomatic for 12 years. In December 2017, he developed seizures. And when he was evaluated, the MRI brain was suggestive of 3 rim-enhancing nodular lesions in the left cerebral hemisphere with variable perilesional edema. So this was the MRI. There was a large lesion in the left occipital lobe, left frontal, and another in the left parietal. Subsequently, keeping in mind that there was a history of renal cell carcinoma, we did a FDG PET CT and we found that there was a 3 by 3 centimeter lesion in the left lung, lower lobe, along with few other nodular lesions in the same lobe. Additionally, there were subcentimetric mildly FDG-avid abdominal lymph nodes. We went ahead and we did a biopsy from the left lung mass and it came out to be a clear cell carcinoma. So we established the diagnosis of recurrent clear cell RCC with brain and lung and lymph nodal metastasis. The IMDC risk score for this patient was good risk. He received SRS for brain mets on 11th of January 2018. Subsequently, he was started on Sutent 37.5 mg, 2 weeks on 1 week off regime from 30th of January 2018. The tolerance to this dose of Sutent was also moderate. There were grade 1 mucositis, grade 2 hand-foot syndrome, and there was grade 2 fatigue as well. However, he completed 3 cycles. After the end of 3rd cycle, there was neurological worsening and he complained of increased imbalanced drowsiness. There was weakness and associated weight loss. Performance status also deteriorated from 2 to ECOG 2 to 3. So after 3 cycles Sutent, because of neurological worsening, and we did a MRI which showed that the number of brain metastases had increased. So now there were multiple brain metastases involving both the cerebral hemispheres. Subsequently, PET CT scan was done which showed that the lung lesion had remained almost stable, but there were new metastases involving the liver and multiple bone metastases, which were new findings. So here we were dealing with a rapid progression, metastatic RCC patient who showed rapid progression in brain, liver and bones after first line TKI. So as we have seen, he was a IMDC good risk patient, but we know that patients with brain metastasis, they have this independent poor risk factor and IMDC does not reflect brain metastasis in the scoring, and he did not behave like a good risk patient. He underwent external beam radiotherapy in the month of May, completed it on 10th of May. Subsequently, he was started on exitinib from 20th May, which was tolerated poorly, and after 1 month, because of severe fatigue, patient himself stopped exitinib. So at this time, performance status was 3. He was symptomatic for extreme weakness, and there were neurological symptoms as well in the form of imbalance. So as a desperate measure, he was started on nivolumab. The first dose was administered on 3rd of July 2018. Subsequently, his general condition worsened. He developed urinary tract infection and pneumonia, and he died of sepsis on 24th of July 2018. So discussion points what I considered in this case is, this point has been discussed to an extent in the last talk, that which first line systemic therapy should be preferred, if there is any, in patients with symptomatic brain metastasis. Now, considering the fact that he was a good risk IMDC patient and immunotherapy as per the Checkmate 214 the good risk patients did better with sunitinib. Patients who progress very rapidly after we start first line TKI, and there are others which progress, say on an average, when the median is reached around 8 to 10, 12 months, and then there are long-term responders who progress after 2 to 3 years. So particularly in patients who progress very rapidly, is there any preferred second line option among all the options which are mentioned in the guidelines? And third point is, how safe is it to initiate immunotherapy after whole brain RT? So there is a concern that there is brain metastasis with associated edema. You give radiation, there can be some worsening in the edema as well. And when we institute immunotherapy, can it lead to worsening of this edema? So is there any specified time interval between radiation completion and immunotherapy? So those are the points which I would want to discuss. Thank you.
Thank you, Dr. So the reason I selected some of these cases are because there are a lot of key points to discuss, and I think the first thing which is not highlighted here, which he mentioned, is about the risk stratification scores that you have, whether it's the Hain criteria or the MSKCC, the Motzer criteria. I think they are not perfect, right? In a case like this, when you see a patient has brain mets and then of course subsequently develop mets everywhere, it is clear that he's not going to perform like a good risk patient regardless of his biochemical parameters, ECOG performance status and things like that. So this is something that I think it's really difficult to address. I think initially when a lot of these criteria came out, it was really dependent on what factors were put into this, what I would call a fishing expedition to get things out of it. And which is why one criteria had LDH and another didn't have, because there was no LDH looked at in the first place in the second criteria. So that's I think the key point that was there at the start. So if you were going to rule out the immunocombination because of that, I think really hard to make that kind of judgment call, because this guy wouldn't really perform like a good risk patient. Now, with regards to first-line systemic therapy, again, there are no dedicated trials for patients with brain mets per se. A lot of it are retrospective data, subset analysis looking at patients who had high-risk features, including brain mets or liver mets. So based on that, maybe I'll ask Naveen, is there any particular treatment that you'll choose over another for patients with brain mets?
No, I think that partly the difficulty is these sorts of patients are all excluded from all the clinical trials, aren't they? So we don't really have any data to really guide us. With the TKIs, that data has principally come from the expanded access real world sort of data, and IO, I'm not aware of any. And I mean, so the short answer really is probably doesn't really matter what you do. I mean, this is unusual, isn't it? It's an unusual case. Usually with these, with the long relapse-free intervals, these are the ones, the patients that do well. And this guy clearly, though, is the other end of the spectrum. I think. I mean, I don't know what you did. The key thing to reduce the risk is to give SBRT and try and gain control of the intracranial disease, and then use the VEGF TKI in the hope that you can control both the extracranial disease and hopefully control his brain metastases. But was he still steroid dependent, or?
Yeah, he was.
He was
at the time of progression, after first line, when there was progression. Upfront also, because he presented with seizures, so we added at that time we added steroids.
Yeah,
but we went on the same line. We gave him SRS and subsequently we added Sutent. So that was the. Yeah, so we don't have ipilimumab available with us, but
no.
Yeah, so that was there in our mind. January 2018 was the time when that data was.
But this is the sort of paradox, or Robbie's alluding to, that technically this guy wouldn't qualify. If Ipilimumab got approved tomorrow, it will be for the intermediate poor risk patients, and so technically he's not eligible.
Yeah, but we would want to give that opinion.
Yeah, actually, again, going back again, one more thing I may have done. He didn't respond to sunitinib, right? And rapidly progressing disease, is also to look back at the histology again. And oftentimes, you may find there are other components there, whether it's sarcomatoid or rhabdoid components, which will not start, which is academic, but it'll explain the disease biology. Yeah, and we've done that. We've got that a few times when we've got a reread here. Patients have come from nearby areas, diagnosed as clear cell, and when we've done a read here, it comes up with other more aggressive components. It will at least explain why the disease behaves that way. But while saying that, you know what, not all patients are going to respond to VEGF TKIs. That's the reality. And for those who respond, it's always going to be challenging to find what drugs to use. Joaquin?
Yeah, remember that Alain Robo did a trial where there is 20% of kidney cancer patients that have this type of behavior, so they progress so quickly. And even in some trials, and this was because of in one of the trials they said, well, these early progressors need to be removed because it was an alternating trial. So they randomized this patient or assigned, I don't remember if it was, to a change to a drug with different mechanism of action, so an mTOR inhibitor, or to continue with another anti-angiogenic therapy, and nothing works. So nothing has been checked about cabozantinib. So cabozantinib, we know that it's much more active than sunitinib. It could be an option, but those quick progressors, if you switch to immunotherapy, because immunotherapy takes like 2 months until it's acting, so you lose the patient. So we don't know what to do with this patient, but yeah, cabozantinib has not been tested and could be an option. For first-line patient with metastatic disease, there is limited data on sunitinib before radiation therapy, but obviously the first thing is to radiate these patients and then to treat with TKI.
I think if cost is not an issue and if progress so rapidly, you could just do an NGS and look for any particular mutations you may think may be the oncogenic driver. As far as I know now, it is relative. There are a lot of options to do that in India as well, right? There's so many companies doing it, and
it's
relatively cheap. So you may want to do that and look at what other targets you may want to get, because this is really not your run-of-the-mill case. Any thoughts on that?
I think the only other option which was there in my mind at the time of rapid progression was a combination of lenvatinib plus everolimus. But he was not fit for that combination. I mean, again, exploring that the other pathway which can be activated, but again, we don't have that.
Yeah, personally, I'm not convinced by the data for Lenive. It's not something that I use. I think it will be toxic, and those combinations. And if you look at the data, it does seem that quite a lot of patients in the combination arm actually dropped the len.